Hope So Too, by Richard E. Leiter, MD, MA. You're always the negative one, Carlos's mother said through our hospital's Spanish interpreter. You want him to die. Carlos was 21 years old. A few years earlier, he had been diagnosed with AML and had undergone an allogeneic bone marrow transplant. He was cured, but now he lay in our hospital's bone marrow transplant BMT unit, his body attacked by the very treatment that had given him a new life. He had disseminated graft-versus-host disease, GVHD, in his liver, his lungs, his gut, and most markedly, his skin. The BMT team had consulted us to help with Carlos's pain. GVHD skin lesions covered his body. They were raw and weeping. Although the consult was ostensibly for pain, the subtext could not have been clearer. Carlos was dying, and the primary team needed help navigating the situation. As his liver and kidney function declined, the need to address goals of care with Carlos's mother felt like it was growing more urgent by the hour. Difficult cases like a young person dying transform an inpatient unit. Rather than the usual hum of nurses, patient care associates, pharmacy technicians, and unit managers going about their daily work, the floor becomes enveloped in tension. Daily rhythms jump a half step ahead of the beat. Conversations among close colleagues fall out of tune. Thank goodness you're here, nurse after nurse told my attending and me, the weight of Carlos's case hanging from their shoulders and tugging at the already puffy skin below their eyes. I was a newly minted palliative care fellow, just over a month into my training. I was developing quickly, but as can happen with too many of us, my confidence sat a few steps beyond my skills. I thought I had a firm grasp on palliative care communication skills and was eager to use them. I asked for feedback from my attendings and genuinely worked to incorporate it into my practice. At the same time, I silently bristled when they took charge of a conversation in a patient's room. Over the ensuing week, my attending and I leaned in. We spent hours at Carlos's bedside. If I had squinted, I could have convinced myself that Carlos's pain was better. Every day, however, felt worse. We were not making any progress with Carlos's mother, who mostly sat silently in a corner of his room. Aside from occasionally moaning, Carlos did not speak. We learned little, if anything, about him as a person, what he enjoyed, what he feared. We treated him, and we barely knew him. Each morning, I would dutifully update my attending about the overnight events. Creatinine is up. Billy is up. She would shake her head in sadness. Doesn't she get that he's dying? One of the nurses asked us. I feel like I'm torturing him. He's jaundiced and going into renal failure. I'm worried we're going to need to send him to the ICU, but even that won't help him. Doesn't she understand? We convened a family meeting. It was a gorgeous August afternoon, but the old BMT unit had no windows. We sat in a cramped, dark gray family meeting room. Huddled beside Carlos's mother was everyone on the care team, including the BMT attending, nurse, social worker, chaplain, and Spanish interpreter. We explained that his kidneys and liver were failing and that we worried time was short. Carlos's mother had heard it all before, from his clinicians on rounds every day, from the nursing staff tenderly caring for him at his bedside, and from us. He's going to get better, she told us. I don't understand why this is happening to him. He's going to recover. He was cured of his leukemia. I have hope that his kidneys and liver are going to get better. I hope they get better, I told her. I should have stopped there. Instead, in my eagerness to show my attending and myself I could navigate the conversation on my own, I mistakenly kept going, but none of us think they will. It was after this comment that she looked me right in the eye and told me I wanted Carlos to die. I knew even then that she was right. In that moment, I did want Carlos to die. I could not sit with all the suffering, his mother's, and his care teams. I needed her to adopt our narrative that we had done all we could to help Carlos live, and now we would do all we could to help him die comfortably. I needed his mother to tell me she understood, to accept what was going on. I failed to recognize what now seems so clear. Of course, his mother understood what was happening. She saw it. But how could we have asked her to accept what is fundamentally unacceptable? To comprehend the incomprehensible? At its best, Serious illness communication not only empathetically shares news, be it good or bad, but also allows patients and families adequate time to adjust to it. For some, this adjustment happens quickly, and in a single conversation, they can digest difficult news and move to planning the next steps in care for themselves or their loved ones. For most, they need more time to process, and we are able to advance the discussion over the course of multiple visits. My attending led the conversations from then on. She worked with the BMT attending, and they compassionately kept Carlos out of the intensive care unit. He died a few days later, late in the evening. I never saw his mother again. I could not have prevented Carlos's death. None of us could have. None of us could have spared his mother from the grief that will stay with her for the rest of her life. Over those days, though, I could have made things just a little bit less difficult for her. I could have protected her from the overcommunication that plagues our inpatient units when patients and families make decisions different from those we would make for ourselves and our loved ones. I could have acted as her guide rather than as her cross-examiner. I could have hoped that Carlos stopped suffering and genuinely hoped he got better, although I knew it was next to impossible. Because hope is a generous collaborator, it can coexist with rising creatinines, failing livers, and fears about intubation. Even on our most difficult moments as clinicians, we can find space to hope with our patients if we look for it. Now, years later, when I talk to a terrified, grieving family member, I recall Carlos's mother's eyes piercing mine. When they tell me they hope their loved one gets better, I know how to respond. I hope so too, and I do.
Hello, and welcome to JCO's Cancer Stories, The Art of Oncology, which features essays and personal reflections from authors exploring their experience in the oncology field. I'm your host, Mikkael Sekeres. I'm Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center at University of Miami. Today, I am thrilled to be joined by Dr. Leiter from the Dana-Farber Cancer Institute. In this episode, we will be discussing his Art of Oncology article, I Hope So Too. Our guest's disclosures will be linked in the transcript. Ricky, welcome to our podcast, and thank you so much for joining us.
Thanks so much for having me. I'm really excited to be here.
Ricky, I absolutely adored your essay. It really explored, I think, a combination of the vulnerability we have when we're trying to take care of a patient who's dying and the interesting badlands we're placed when we're also a trainee and aren't quite sure of our own skills and how to approach difficult situations. But before we dive into the meat of this, can you tell us a little bit about yourself? Where are you from and where did you do your training?
Sure. Yeah. Thanks so much. So I grew up in Toronto, Canada, and then moved down to the States for college. I was actually a history major, so never thought I was going to go into medicine. And long story short, here I am. I did a post-bac, did a year of research, ended up at Northwestern Feinberg School of Medicine for med school, where I did a joint degree in medical humanities and bioethics. And that really shaped my path towards palliative care because I found this field where I said, wow, I can use these skills I'm learning in my master's at the bedside with patients, thinking about life and death and serious illness and what does that all mean in the broader context of society. So moved from Chicago to New York for residency, where I did residency and chief residency in internal medicine at New York Presbyterian Cornell, and then came up to the Harvard Interprofessional Palliative Care program, where I did a clinical fellowship, then a research fellowship at Dana-Farber, and have been on faculty here since.
Fantastic. Any thoughts about moving back to Canada?
We talk about it every now and then. I'm really happy here. My family's really happy here. We love life in Boston. So we're certainly here for the time being, definitely.
And the weather's so similar.
Yeah, you get used to the cold.
I apparently did not move to Miami. I'm curious, this may be an unfair question, as you have a really broad background in humanities and ethics. Are there one or two books that you read where you think, gee, I'm still applying these principles, or this really still resonates with me in my day-to-day care of patients who have cancer diagnoses?
Oh, wow. That is a great question. There are probably too many to list. I think one is When Breath Becomes Air by Paul Kalanithi, which I didn't read in my training. I read afterwards. And I think he's such a beautiful writer. The story is so poignant. And I think Paul Kalanithi's insights into what it means to be living with a serious illness and then ultimately dying from cancer as a young man, as someone in medicine, has really left an imprint on me. Also, Arthur Kleinman, The Illness Narratives, I think is such a big one too. And similarly, Arthur Frank's work. I mean, just thinking about narrative and patient stories and how that impacts our clinical care and also us as clinicians.
And I suspect us as writers also.
Absolutely.
We imprint on the books that were influential to us.
Certainly.
So how about your story as a writer? How long have you been writing narrative pieces? Is this something you came to later in your career, or did you catch the bug early as an undergrad or even younger?
So I caught it early and then it went dormant for a little while and came back. As a history major, as someone who was humanities minded, I loved writing my papers in college. Like I was one of those nerds who got like really, really excited about the history term paper I was writing. It was difficult when I was doing it, particularly at the last minute, but really loved the writing process. Going through my medical training, I didn't have as much time as I wanted. And so writing was sort of on the back burner. And then actually in my research fellowship, we had a writing seminar in our department. And one of the sessions was on writing op-eds and perspective pieces. And we had a free write session. And I wrote something sort of related to my research at the time I was thinking about. And Joanne Wolf, who was helping to lead the session, pediatric palliative care physician, and she said, this is really great. Like, where are you going to publish this? And I said, Joanne, what do you mean? I just wrote this in this session as an exercise. She said, no, you should publish this. And I did. And then the bug came right back. And I thought, wow, this is something that I really enjoy. And I can actually make a difference with it, getting a message out, allowing people to think a little bit differently or more deeply about clinical cases, both in the lay press and in medical publications. So I've essentially been doing it since, and it's become a larger and larger part of my career.
That's absolutely wonderful, Ricky. Where is it that you publish then outside of Art of Oncology?
So I've had a couple of pieces in the New York Times, which was really exciting. Some in Stat News on their opinion section called First Opinion, and had a few pieces in the New England Journal as well, and in the palliative care literature, so Journal Palliative Medicine.
Outstanding. And about palliative care issues and end-of-life issues, I assume?
Sort of all of the above: palliative care, serious illness, being in medical training. I wrote a fair bit about what it was like to be on the front lines of the pandemic.
Mm-hmm. Mm-hmm. Yeah. That was a traumatic period of time, I think, for a lot of us.
Absolutely.
I'm curious about your writing process. What triggers a story, and how do you face the dreaded blank page?
So it's hard to pin down exactly what triggers a story for me. I think sometimes I'm in a room and for whatever reason, there's a moment in the room and I say, you know what? There's a story here. There's something about what's going on right now that I want to write. And oftentimes I don't know what it is until I start writing. Maybe it's a moment or a scene and I start writing. It's like, what am I trying to say here? What's the message? And sometimes there isn't a deeper message. It's the story itself is so poignant or beautiful that I want to tell that story. Other times it's using that story. And the way I think about my writing is using small moments to ask bigger questions in medicine. So like, what does it mean to have a good death? One piece I wrote was thinking about that as I struggled to give someone what I hoped would be a good death, that I was thinking more broadly, what does this mean as we're thinking about the concept of a good death? Another piece I wrote, it was about a patient I cared for doing kidney palliative care. And she was such a character. We adored her so much and she was challenging. And she would admit that this was someone I wanted to write about. And I talked to her about it. And she was honored to have her story told. Unfortunately, it came out shortly after her death. But it was, she was such a vibrant personality. Said there's something here that I want to write about. In terms of the blank page, I think it's overcoming that fear of writing and the procrastination and all of that. I think I have a specific writing playlist that I put on that helps me, that I've listened to so many times. It, no words, but I know the music, and it really helps me get in the zone. And then I start writing. And I think it's one of those things where sometimes I'm writing like, oh, I really don't like how this is sounding, but I'm going to push through anyways as Anne Lamott's blank first draft, just to get something out there. And then I can play with it and work with it.
Great. I love the association you have with music and getting those creative juices flowing and picking le mot juste in getting things down on a page. It's also fascinating how we sometimes forget the true privilege that we have as healthcare providers in the people we meet, the cross-section of humanity and the personalities who can trigger these wonderful stories.
Absolutely. Absolutely. It's such a privilege. And I think it often will go in unexpected directions and can really impact, for me, certainly my practice of medicine and how I approach the next patients, or even patients years down the road. You remember those patients and those stories.
Right. You write with such obvious love and respect for your patients. You also write about that tenuous phase of our careers when we're not yet attendings, but have finished residency and have demonstrated a modicum of competence. I used to say that fellowship is really the worst of all worlds, right? As an attending, you have responsibility, but you don't have to do as much of the grunt work. As a resident, you do the grunt work, but you don't really have the responsibility. And in fellowship, you got it all. You've got to do the grunt work and you have the responsibility. Can you tie those two concepts together, though? How does our relationship to our patients change over the course of our careers?
Early on, if you think about the imprinting of patients as you go down the road, so many of the patients who have imprinted on me were the ones earlier in my career, before I was more formed as a clinician, because of experiences like the one I wrote about in I Hope So Too, where the skills are forming, and sometimes where it's smooth sailing and sometimes we're muddling through. And those cases where we feel like we're muddling through or things don't go as we hope, those are the ones that really leave an impact. And I think it's those little moments that sort of nudge your career and your skill set in different ways. I think the patients now, they still leave a mark on me, but I think it's in different ways. And I think oftentimes it's less about my skills, although my skills are still very much developing, even, almost a decade out. They impact me differently than they once did. I feel more confident in what I'm doing. And it's more about my relationship to this situation rather than the situation's impact on my skills.
Got it. Got it. It's interesting. I once wrote a piece with Tim Gilligan, who also spent some time at Dana-Farber and is a communications expert, about how there's this kind of dualism in how we're trained. We're trained with communications courses and how to talk to patients. And it almost does the opposite. It kind of raises the flag that, wait a second, maybe I've been talking to people the wrong way. And as you get more mature in your career, I almost feel as if you revert back to the way you were before medical school, when you just talked to people like they were people and didn't have a special voice for patients.
Yeah, I think that's right. And I think in palliative care, we spend so much time thinking about the communication. And this was the most challenging piece about fellowship, because and our fellowship directors told this to us, and now we teach it to our fellows, that you come in, the people who choose to go into palliative care have a love of communication, have some degree of skill coming in. And then what happens is we break those skills down and teach them a new skill set. So it gets clunkier before it gets better. And the time I was writing about in this piece was August of my fellowship year, exactly when that process was happening, where I'm trying to incorporate the new skills. I had my old way of doing things, and it's just not always aligning. And I think you're right that as the skills become embedded as you go on throughout your career, where it feels much more natural. And then you do really connect with people as people, still using the skills and the techniques that we've learned in our communication courses, but they become part of who you are as a clinician.
Nicely put. Your story is particularly poignant because the patient you described was dying from the very treatment that cured his leukemia. It's this, I'm going to use the term badlands again. It's this terrible badlands we sometimes find ourselves where yes, the treatment has been successful, but at the cost of a human life. Do you think that as healthcare providers, we react differently when a patient is sick from side effects to our recommendations as opposed to sick from their disease?
I think we probably do. It's hard because I think every patient in every case pulls at us in different directions. And this case was Carlos, who I called him. It was such a challenging situation for so many reasons. He was young. He really couldn't communicate with us. We were talking to his mom. Like, there were so many layers to this, but I think you're right that underlying this, there's a sense of we did everything we could beautifully to cure him of his disease. And now he's dying of that cure. And what does that mean for us as clinicians, physicians? That becomes really hard and hard to sit with and hold as we're going back every day. And I say that as the palliative care consultant. So I can only imagine for the oncology team caring for him who had taken him through this, what that felt like.
Well, you describe again beautifully in the piece how the nursing staff would approach you and were so relieved that you were there. And it was, you got the sense, I mean, there's obviously, it's tragic because it's a young person who died, but you almost got the sense there was this guilt among the providers, right? That not only is it a young person dying, but it's dying from graft-versus-host disease, not from leukemia.
Absolutely. There was guilt because of what he was dying of, because how he was dying, that he was so uncomfortable. And it took us so long to get his pain under control. And we really couldn't get him that balance of pain control and alertness that we always strive for was pretty much impossible from the beginning. And so it was layer upon layer of distress and guilt and sadness and grief that we could just feel every day as we step onto the floor.
Yeah, yeah. I don't know if you've ever read, there's a biography of Henry Kaplan, who was considered the father of radiation therapy, where there was this incredible moment during his career when he presented at the AACR annual meeting the first cures for cancers, right? No one believed it. It was amazing, actually curing cancer. And then a couple of years later, people started dribbling into his clinic with cancers because of the radiation therapy he gave. And he actually went into a clinical depression as a result of it. So it can affect providers at such a deep level. And I think there's this undiscussed guilt that permeates the staff when that happens.
Absolutely. Absolutely. It's right there under the surface. And we rarely give ourselves the space to talk about it, right? To really sit down and say, how are we approaching this situation? How do we feel about it? And to sit with each other and acknowledge that this is horrible. It's a horrible situation and we feel guilty and we feel sad and we feel grief about this.
It's been just terrific getting to know you and to read your piece, Ricky Leiter, and we really appreciate your writing. Keep doing what you do.
Oh, thank you so much. It's a privilege to get the piece out there, and particularly in JCO, and to be here with you. So I really appreciate it.
Until next time, thank you for listening to JCO's Cancer Stories, The Art of Oncology. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all of ASCO shows at asco.org/podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.